I'd like to just run through a little bit of an understanding about the disparity when you look at health and perinatal statistics in the north compared to the south. And really, what was the beginning of the outreach program, what it is, how do we do it, and what is the future? If you draw a line across the Tropic of Capricorn, you can divide Australia into two pieces. You've got the north and the south. And you can see from the perinatal statistics that I've put on the diagram that there is a vast disparity. You've got an increased risk of stillbirths. You've got a 2 to 4 times the risk of maternal death. And you've got an increase in preterm birth in the north compared to the south. There are many, many potential reasons for this. Firstly, the population is a very low population in the north compared to the south. In addition, there are not many perinatal services that exist within the north. And obviously, we need more perinatal specialists, and we need people to be able to cope and manage the extra morbidity and/or prevention of mortality in these areas. My inquisitive nature at the start of my ONG training took me to Darwin, and I asked the question, but why? Why are there increased preterm births? Why are there poorer outcomes? And so we ended up cutting up about 192 placentas from locations all over the north that you can see here on the map. The majority were obviously from Darwin, but there was a significant component of rural and remote placentas from women delivering at Royal Darwin Hospital during a 3-month period. I sectioned, weighed every placenta and put them onto slides. And then Dr. Susan Arbuckle was blinded to the clinical outcome, looked at the placentas, and then she recorded her results. When we went and did an adjusted regression analysis, we actually found that rural and remote women and their placentas had higher rates of placental inflammation compared with metropolitan, and also there was no difference in ethnicity. So Aboriginal and Torres Strait Islander women had no significant difference to placental inflammation. It was actually those women that lived remotely, and of course there are a higher proportion of Aboriginal and Torres Strait Islander women who do live remotely in Australia. So that was a really interesting finding, and that sort of did shape the direction of my career from there. So remoteness has all of these different aspects. We have weather-related conditions, low population numbers, as I mentioned, high proportion of First Nations, in addition to food insecurity, which contributes to malnourishment, along with disparity in job opportunities and education, housing issues, sanitation issues, and then not to mention the significant and vast distances it takes for people to get to healthcare services, along with the lack of specialists and the lack of continuity, particularly in remote areas of healthcare professional staff. All of these aspects mean that probably remoteness is related to systemic disadvantage, and we can actually, it's difficult to measure and quantify, but remoteness as an entity itself could represent the actual cause of the disadvantage. So North Queensland, let's look at that, and that's where I am at the moment. So Townsville has, the North Queensland has a population of 700,000. and 12.3% identify as Aboriginal or Torres Strait Island. 10,000 deliveries per year in this area, and 800 of those babies are admitted into the NICU in Townsville, and 27% are actually from remote or very remote areas. So that's 1/3 of babies. When we actually did an audit of extreme prematurity in Townsville Hospital, we found that there were significant factors, including BMI, smoking, a high rate of inter-hospital transfer, 60%, and then a higher proportion of First Nation mothers experiencing preterm birth and extreme prematurity. And when we went back and looked at their notes and saw that they had actually had a previous preterm birth, 90% of them did not have the interventions that they needed to have to prevent a preterm birth in a subsequent pregnancy. So these are potentially preventable. What about hypertension? We know that preeclampsia is increased in women who identify as Aboriginal and Torres Strait Islander. And we found that in some of the remote communities that we were visiting, up to 9% were affected by preeclampsia, compared with an overall rate of 2.3% in Queensland. When I first arrived into Townsville, I noticed that there was more eclampsia that I'd seen in 1 year in Townsville than I'd seen in my career in New South Wales and in my training. And this was 3 times the national rate when I did an audit of the eclamptic fits in the north. I've got a great honours student who is actually just finished her scoping review, which basically showed that the literature is heterogeneous and very limited when we look at comparisons between rural and remote versus metropolitan in terms of hypertension, preeclampsia, and outcomes such as low birth weight and SGA related to that. So we're currently, and her honours project is currently looking at the impact of remoteness on maternal and perinatal outcomes in Queensland. And we're looking at over a 4-year period with over 240,000 deliveries. I want you to now just reset, now that we've talked about understanding why this is really important, is to actually put yourself in this mother's shoes. She's a mum of 3 children. She lives on Mornington Island. She's pregnant with her 4th, excited, unplanned, but very excited about a 4th baby. But what are the barriers for her attending a routine ultrasound and her routine pregnancy care in her maternity hospital, which is in Mount Isa, which is over 700 kilometres away from her? So her family commitments are very, very strong, and she often can't just get up and go. The financial impact of that is huge. The transportation to and from the airport and the hospital is something that worries women a lot when they're from out of area. Often women are okay to go and they're happy and they're planning to go, but then their appointments are cancelled because there is no accommodation to enable them to stay for the ultrasound and to stay for 3 or 4 days either side of their ultrasound. And then obviously they have the care of their other children, and sometimes women report that they don't have someone safe to leave their children with. And also those that are working mums, they have a loss of income for that entire week that they're away. I know that if that was me, I wouldn't go to my routine pregnancy ultrasound or care in another town 700 kilometres away. And I don't know how all of you feel, but that's how I would feel if I put myself in this woman's shoes. So what can we do about it? Well, we can get on a plane and we can go to women. And basically that's what this talk is about. And the story began about 20 years ago, well before I was ever involved. And it was a fantastic Queensland Health funded sonographer and midwifery team, Sue Bloomfield and Alex Gusden. And they together began a program by going to women on Palm Island and facilitating opportunistic care at the time of ultrasound. And over the years, it evolved into an obstetrician and a sonologist going, and that was me, and I was extremely privileged and honoured to be involved. We integrated and resided in a location where we worked with the local GPs, and we facilitated and worked with the Joyce Palmer Hospital on Palm Island, and worked with the visiting allied health professionals and Aboriginal health workers. Over time, we had more and more pregnancies, not enough ultrasound time, and so we approached Checkup Australia for further funding. And that funding gave us extra visits for ultrasound, but they also asked for me to be a gynecologist. So I put my gynecology hat on, and I do facilitate some office gynecology while I'm there as well. And this is where the Care on Country program started. So within a few months of these extra visits on Palm Island, we were then called up by Checkup Australia to say that Mornington Island in the Gulf of Carpentaria wanted the same service. And so did Doomadgee, and so did Normanton, Corumba and Burketown. And so that's how we started this process. So you can see in that area that we've done and we've started our outreach, there's approximately about 200 births, give or take. And when we look at the perinatal statistics over the last few years, of those 200, 18 would develop preeclampsia based on the current statistics, and also 30 would have a preterm birth. And that just gives you a little bit of a context of what the patient demographic is like. So the aim of our program was to provide culturally safe care for women. We used ultrasound as a connector, and talking about connection, as Natalie has talked about, and reducing travel for routine pregnancy investigations, training local staff in both ultrasounds, early dating, and obstetric and antenatal care. And then also instigating primary, secondary and tertiary prevention strategies to reduce the chances of obstetric complications. We partnered with all these incredible organisations. The Palm Island Community Council has been a great supporter for us, and we've really enjoyed working with the team. TARS, we've started working with in the last 6 months, and it's been a fabulous working relationship. I'm still involved with Townsville University Hospital and Checkup Australia. The PHN are our funding bodies, and the Northwest as well, that we integrate with the Gulf of Carpentaria service. Our equipment is very, to a certain degree, basic, and we started off very basic, and we've increased our tech over the last sort of 12 to 24 months. We started off with a very simple portable ultrasound, and we use Starlink as our connectivity, and we basically upload images into Trisify, which is a cloud PAC system, and then that then drops into my Viewpoint so that I can then report using a Viewpoint software. And then we have a practice management software that is web-based, so it doesn't need to be connected to a server. The challenges, connectivity was our biggest challenge, and it took us a while to work out that Starlink was the only way that we could get the images up to the cloud easily without delay. The equipment, often we didn't have gynae beds, and particularly when we started. We do now have gynae beds, but that was very challenging, and so we had to do a lot of MacGyvering in making beds more suitable for women during gynecological examination. And then we were met with a lot of excitement at Mornington Island that these were our ultrasounds, and how proud they were of their ultrasounds. And I had a little giggle because that's what I started ultrasound on, the sono site, and brought back lots of memories. But obviously we couldn't do morphologies on that. And then obviously the big wet, the cyclones, huge amounts of rain and flooding would often stop or delay our trips. And the age-old challenge, forever challenge of funding. This is our first trip in July 2023, and this was a lovely patient of ours who agreed to be scanned, and this was the resident ultrasound machine, which was pretty good in Normanton Hospital. It was an S8 GE machine, and so we were able to, with our connectivity to Trisify, use that machine to do most of our imaging, which was incredible. But obviously it didn't have any 3D capabilities or any updated fancy fetal heart settings. Then, with much excitement, after you saw the ultrasounds that existed on Mornington Island, they then purchased a Voluson Swift, and that's been a great source of excitement for the community because we now have a very, very high level, fairly basic machine, but it can do everything that we want it to do, and the girls love the 3Ds, so that's been a win. I wanted to show this. This is one of my favorite photos because ultimately we want the next generation of kids to become sonographers. And my pipe dream would be to have the kids grow into beautiful sonographers in their local communities and be doing their ultrasounds themselves. And having people like me and other MFMs reading their images and connecting with them. And I think that this is the pipe dream. And this little kid actually had a very good eye. And there's the pregnancy there. So this little girl did very well. This is what it looks like. 32 months now that we've been going, and we go once a month. We were increasing our visits up to fortnightly, but unfortunately the expense of that was too much. So we ended up having to then go to monthly with ad hoc visits if required. You can see that their weather events definitely disrupted some of our visits, but overall the general uptake has been incredible. And we're now seeing on average 40 to 50 women every month in the communities. Overall, with the Women's Health Circle, which is the parent company, we've scanned over 5,000 women in rural and remote North Queensland and Northern Territory. We've performed over 9,000 ultrasounds in the care on country, so delivering this service to women on country, that's now up to over 1,000 ultrasounds. We've done over 782 first trimester screening and preeclampsia screening, which has been very exciting to bring that to the north. In terms of the classification of some of the ultrasound findings and referrals, about 60% of what we do in community is absolutely normal and doesn't need any action and can have routine care. The rest of it is complicated and does need some input, sometimes a formal MFM input, sometimes it needs a high-risk obstetric hat and a maternal medicine hat. But we've had caesarean scar ectopics, we've had a complete molar pregnancy, which was up to the umbilicus before diagnosis in the middle of a remote community, and she just started bleeding the day before. We had a baby that nearly didn't make it, which had an acute placental insufficiency at 35 weeks, and we had to fly off, and that baby is doing very well. We've had mums with coronary artery bypass stents. We've had warfarin, mechanical valves, goiters, thyroid cancers causing obstructive tracheal symptoms. We've seen lots of threatened preterm labour, shortened cervixes, and been able to initiate progesterone and ongoing monitoring and counselling. We've been able to identify women at risk of preeclampsia, initiate aspirin and further growth scans. We've picked up some complex cardiac anomalies, renal abnormalities and limb differences. And we've also had a live ectopic remotely, which we're able to, with Mount Isa, amazing management, able to get that patient there within the day, and she was operated on that night and had a very good outcome. And we've also done lots of assisting with termination care and miscarriage management in the community and helped to keep women in their communities for those procedures. What's the impact on health outcomes? So we've done some audit data and we are going to be presenting this further on with more detail at a later date. But overall, we've had a big reduction in low birth weight infants, up to 50%. We've had a reduction, and that's a small reduction in fetal growth restriction. We've had a small reduction in preeclampsia, a moderate reduction in preterm birth, and we've also increased the detection of placental insufficiency, which is a major cause of stillbirth. Thanks to Townsville Hospital for giving me some data just to add to the story. And this is looking at just Townsville, and we've started a new program with the Townsville Aboriginal Controlled Health Organisation, and we've seen a steady improvement in the local Townsville birth weights since women have had culturally safe access to ultrasound and pregnancy screening. So that's been great. The impact on the health services. So we've had a reduction in planned commercial travel to routine appointments, which has been a significant amount of money. We've minimised delays in the setting of a high-risk result or an abnormal ultrasound. We've seen a reduction in emergent error medical retrievals, which again is a big cost to the healthcare system. And we've also been able to initiate and start primary and secondary prevention strategies, which is in line with what metropolitan women receive as their standard care. So we've also been so lucky, and a big shout out to KPMG, who have done a formal economic analysis, and I was hoping to present this today, but we haven't got the official full sign off yet, but they said I could just introduce the concept that this is coming. And they've looked at all our costings for the program, which over the last 2.5 years has amounted to about $1 million, which includes staff costs, consumables, diagnostic equipment, and travel. And this is definitely not part of their analysis, but this was what I had put together prior to KPMG doing a formal economic analysis. But we're at least saving $3,000 per patient per travel per scan. So you can imagine how much we have saved the healthcare service. So that's about $3 million on its own. When we look at the social bank value calculator of reducing stress, reducing financial burdens, improving women's confidence in the service locally, that has been attributed to about 1.5 million. And then using some of Prof. Newman's cost analysis in relation to preterm birth, we've extrapolated it to some of our numbers, and we're estimating about $1 million saved in just that. And that's very conservative, but we're looking at that plus more in terms of the cost savings. So it's highly significant. In terms of our evaluations, we've had great evaluations, and the women just absolutely love the service. You're going to hear about this in a minute when I put on our videos. And 100% of the women received the help that they wanted to, and they felt listened to, which is exactly what we want. So we are fulfilling some of the closing of the gap criteria as well, and the KPMG report outlines this in more detail. So to summarise, we've improved the access to routine pregnancy ultrasound and care. We work collaboratively with a whole range of different people. We do training and education, capacity building in local communities, and our benefit to cost ratios are highly significant. What does the future look like? So the yellow stars are what we're actually currently doing, and the purple stars are where we're actually liaising with new communities to look at whether we can expand the project and the program out to their communities so that more women can access their service at home. Where to next? Sustainable funding, of course, and we've been very lucky, and a big shout out to the North Queensland PHN, who have come on board for another 12 months with us, which we're very excited about. And part of that funding is going to additional communities. So that's what the next sort of 6 months is going to be. We'd like to have a larger team. We have a visiting physio, which is wonderful. We have the midwives that come from Mount Isa and join us on our outreach. But I would also love to have nursing and a pharmacist as well, because there's no pharmacists in any of the remote communities. And a lot of what I end up doing is facilitating medications and teaching women about the medications. So I think a pharmacist would be absolutely paramount out there to make sure that women are getting the medications in a timely fashion. We're partnering with the communities to do prospective research projects, and that's ensuring data sovereignty as well. And I think that that's where we always want to be, is that this is driven by the communities, for the communities, and we are there to assist and help, but we want to improve the local capacity. And we also want to do education and training and upskill as many of the local staff in an early dating scan, so that they can contact us and say, I think she's about 8 weeks, and we want to book her in for her nuchal scan and preeclampsia screen at 12 weeks. And that's where I'd love to get to.
Great. Thank you. Cecilia, thank you. It's an extraordinary program, and it sort of beggars belief that even that back of the envelope calculation of cost effectiveness, that you are having to live 12 months to 12 months.
Yes.
What's the sustainability funding proposal? What does it look like?
What does it look like? Well, we were waiting on the economic analysis.
Yep.
Yeah, so we could go to Queensland government and say, we would like to have recurrent funding. We would like to go to more communities and be able to actually try and use this as a model for women that don't have any access to ultrasound in their hometown. And I think that this has all proven that this is acceptable by the communities. It's cost effective. We're helping in terms of the outcomes, reducing morbidity. And yeah, I think overall, I think it'd be, hopefully the Queensland government will come to the party and fund us recurrently. I'd love to see it develop into something like Deadly Ears, where you have a set program with set clinicians going to set communities, and you have a rotating system. And I'd love to see something like that for the future for women's health.
Absolutely.
Yeah.
There's a question here, with closing the gap funding, why isn't this available to all Indigenous communities?
Oh, it's a great question. I don't actually think that, I mean, I think that a lot of pregnancy related care and ultrasound related care is all state-based and within the health systems. But I agree with you. I think that this is something that is closing the gap. It's federally funded. We should be thinking about it more on a national level rather than an individual state level, because our states are so pushed financially with delivering basic hospital care. And so this preventative type of perinatal care that we're trying to, deliver is something that I think, the federal government should really, really look at. And I think the economic analysis will prove that. I think all the work of the National Preterm Birth Alliance, Stillbirth Alliance, all of that incredible work in a national forum is going to shape perinatal care. But particularly, we need to be focusing on rural and remote women. I think this is where I think, we've proven that something so simple and so cost effective can work. This is where we need to be. Yeah.
Cecilia, thank you. Just a brilliant talk. I'm conscious that we're coming up to time,
yes.
But it was just a brilliant talk, and I suspect that you'll all agree it's been a fascinating twilight tonight. I think we've been asked to step in other people's shoes, and in each of those shoes, those people are saying, don't leave us behind. A fantastic summary from Kelly about one of the groups in the population who are most likely to not access medical care, and how do we reach out and help to bring transgender people across the bridge to be able to get the pregnancy care they need. We've heard from Nat just a fascinating perspective on what it's like for a baby to live in NICU, and I think it's probably blown all of our minds in a small and a big way, and just the interventions that can and should be offered to make sure that the person who is at the centre of NICU care, that their experience is fundamentally embedded in connection. And then finally, we've heard about we all understand as Australians, and some of you are from Canada and others also understand this concept of very remote care, where there's very low density population, but where it's a population with relatively small numbers, but who can so easily be left behind. And what we've heard from Cecilia is that it doesn't have to be like that. It doesn't have to be 700 kilometres driving in each direction and thousands of dollars and fragmentation of care, and sometimes just opting out of care altogether. That there is an opportunity for us to provide meaningful in-reach, and that you can see that it can be done cost effectively, and it can reduce the major obstetric syndromes that, as she said, primary and secondary prevention of those things are the bread and butter that everybody expects in metropolitan and, you know, local regional care. And I think tonight has really popped my equity glasses on. I think we're all looking at equity and
Yes.
just salute the three of you for the way that you are contributing to make better care for everyone and to make sure we leave no one behind. So thank you, Cecilia. Thank you, Nash. Thanks, Kelly. Thanks to Ali, to Bella, to everybody who's joined us tonight. And we look forward to seeing you for Global Obstetric Journal Club about Prevent PE. That'll be next Wednesday. We'll be coming to you from Cape Town. And then fetal growth restriction, what all the international big dogs think about that. And that'll be from Perth in 4 weeks' time. So thanks, everybody, and good night.